Thank you, Anthony, and thank you, Greg, and the organizers for giving me the opportunity to speak today. So I'm a neurologist and fortunate to be one of the precision medicine centers of excellence in multiple sclerosis. But to make my comments more broadly applicable, I thought I'd start out by just commenting that we have an aging society. All of our brains are atrophying with time. Men start out with bigger brains, but they atrophy faster than women. And I'm told that's because we use them less. It's in disease, in a variety of different neurological diseases, we know that the brain atrophies faster than the normal rate of aging. And so I thought I'd tell you a little bit about some of the technologies that we're using in multiple sclerosis to try to estimate disease severity, prognosticate early on, some of the problems that we're facing right now in precision medicine, and how solving these will add value to healthcare in general. So MS is a very heterogeneous disease process. For those of you who aren't familiar with it, it's an autoimmune disease, usually presents in young people aged 20 to 45, affects women twice as commonly as men. And there are a variety of different outcomes, from some people who can go 40 years with the disease and you wouldn't know that they have MS looking at them, to people who end up in a wheelchair rather quickly. And we have a very crude rating scale that we use in the clinic and for clinical trials that the FDA still accepts the primary outcome measure for phase 3 clinical trials. But by the time you sort of reach one of those milestones, it's almost too late to turn back. And so we need predictive tools that will allow us to determine early on who's following a more severe course and does it warrant being on one of the more aggressive therapies that we have. So much like you'll hear with cancer, we have a variety of different therapies. Some are more aggressive with more side effects, and some are milder, and some of our patients probably don't need to be on therapy at all. And so we're in the business of trying to predict in the first year of diagnosis, or the first couple of years, who are the people who are having sort of markers that would suggest that they have a more severe course and should go on these aggressive therapies, and who shouldn't. And we could save, I think, society a lot of money because the therapies themselves are expensive. However, if we undertreat people and let them degenerate from the immune damage to the brain and spinal cord, we'll end up with many more disabled people. So this slide kind of depicts what I was just mentioning to you, that there are some people can be benign for relatively long periods of time, as you can see here, and some people start to progress quickly and develop more brain atrophy. And these are just three different examples of MRIs, and you can probably see from the back of the room that the person on the far right there has the most brain volume loss. And to make matters more complicated, and I'm only just really skimming the granularity of this disease process, the lesions can occur in the gray matter, where we don't see them very well, or in the white matter, where they're known to classically be evident, but imaging technologies are now starting to be able to discriminate these, and looking at volume loss or atrophy turns out to be a very accurate way of determining how much gray matter loss is. And the gray matter is kind of like the hard drive of the brain. That's what really determines whether you're going to have dysfunction. And this just showing you this disease course as depicted by the patients who clinically at the bedside, we recognize that patients can have relapses, and they will complain of these, but for every one relapse there are new lesions forming that we can detect on the MRI. And if we intervene during this stage, when the lesions are forming and the immune system's attacking the brain, we can have better outcomes. If we wait too long, we get into a progressive stage that's more degenerative, and there's less we can do right now, but we're also in the business of trying to understand the biology of that, develop better therapies, and having ways of precisely measuring the neurodegeneration. We can then go to pharmaceutical companies and say, in a phase 2 clinical trial, give them a go, no-go decision on whether a neuroprotective drug has worked in a 6 or 12-month period of time, whereas clinically we would have to wait 2 years before a patient has reached a meaningful outcome. So there are a variety of different applications, both in the clinic and in clinical trials for these imaging technologies. And I don't have time to go through all the literature, other than to say there have been some crude attempts at showing that brain imaging and atrophy do predict outcomes. This is just one study. There's another one from a group at Queen Square in London showing that brain volumes in the early 90s predicted outcomes 20 years later. So this is relevant to disease outcome. I'm going to skip through this for the sake of time. MRIs are really expensive, so they're $1,200 to $1,400 per scan, so we have been also looking to see if we could develop a new technology that could also give us microscopic information about brain health, and recently become very enamored with a technology called optical coherence tomography, which uses near-infrared light that's shined through the pupil, and based on the reflectivity patterns off the back of the eye, the retina, we can estimate the health of the different nerve layers in the eye. The retina is actually part of the brain. A lot of the ophthalmologists study the retina specifically, but the neurons and the cell bodies there are considered part of the central nervous system and project back, obviously, to the thalamus and the back of the brain, the visual cortex. And so it stands to reason that imaging this part of the brain from outside the body with the high-resolution device might be useful. We have about 10 years of data now showing that OCTs actually can help us predict disability and track disease. They're very user-friendly, so we have 3 of these in the Johns Hopkins Outpatient Center. They take about 10 minutes to acquire and to scan. In terms of cost, it's about $100 instead of $1,200, and they're very reproducible and user-friendly, which is nice. And I think I've probably skipped through all these studies other than to say that initially it was thought that this would only reflect focal disease in the back of the eye, but we have been pleased to find out that imaging the back of the eye has broader relevance for telling us about the global health of the brain, even in the absence of clinical attacks. And when patients come in, they can come in with optic neuritis and we'll see a big change in the back of their eye, but even in the absence of any clinical complaint, we see changes over the years in patients who are having neurodegeneration. So this technology has gotten so much attention that it's being applied in Parkinson's disease, Alzheimer's disease, and not surprisingly in traumatic brain injury, concussive injury, in the context of athletes in the National Football League who might be experiencing microscopic neurodegeneration. And the point is that if we could accurately quantify this and track it over time, we might have an early indicator of who's getting into trouble before they're actually having clinical symptoms. And this is one study that we were part of a collaborative group where we pulled our data with groups from the European Union, and we were able to show that a baseline scan predicted the likelihood of disability in the next 2 or 4 years with a quadrupling of risk. If you start out already with microscopic damage in the lowest tertile, you have 4 times the risk of becoming disabled in the next 5 years. So this has prognostic value immediately, and we're starting to use this in the clinic, but we also think that we could use these quantitative imaging technologies to ask other questions about genetic susceptibility to degeneration, because not everyone follows a more aggressive phenotype, or to validate other kind of biomarkers in the blood. And so we're excited about these technologies. We have a NIH-funded study that's now going hopefully into this next 10-year period, looking at the ability to sort of link the retinal degeneration information with brain imaging as a whole. But as I mentioned, we have a fair bit of data, a rich data set at Hopkins, but some of the issues that we're facing right now is how to get this data quantified in a real-time fashion, how to, right now we send it in batches to engineers who over at the Homewood campus who help us do post-acquisition image processing, and 6 months later we might get a batch and we look at the relationships with clinical outcomes and write a paper to further validate it, but it's not in a user-friendly format. And so we've been working with Jerry Prince and other people to have a graphical user interface in the clinic that we could upload the data into our electronic medical record and have a dashboard that shows what's happening to your patient's retina or brain volume, and use this kind of information actually to start making clinical decisions about, are you on an aggressive enough drug to stop the immune-mediated degeneration in your brain? One of the issues that, of course, we confront when we move from a idealized research setting into the clinical setting is that the data are not quite as clean and quality controlled as we would like. So in the research setting, we always use the same scanner, and there's quite a bit of attention to acquisition detail and post-processing detail. And when you go into large volumes, you have to figure out ways of taking data from different sources and then harmonizing them such that they can be used in a longitudinal fashion and have normative data that could be harmonized. Because if I can tell you that the data from the Kirby imaging research scanner is quite different from what you might get at White Marsh or in Bethesda. And so one of the challenges that we hope that engineers can help solve for us is how to take all this clinical required scan information and come to at least common denominator that we can then harmonize them all and put them back into EMR for clinical utility and further validation. And I think the same kinds of issues, just to come back to the broader picture, are being faced with the Baltimore longitudinal study of aging, where they're tracking people with brain volume metrics to try to find out who's undergoing brain atrophy faster and if that relates to lifestyle issues. So with that, I think I will stop and turn over.